We will do almost anything to relieve pain, but where does relief turn into addiction, which can cause additional health problems? Risks of daily opioids for pain, tonight on Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. Before we start tonight's show, I want to tell you about the show we recorded last week when our friends at Public Broadcasting were running the basketball playoffs, which were great. Our crew came into the studio and we were joined by Dr. Tom Dean. We talked about the high costs of health care and some of the reasons they have grown to the present levels. That program is not scheduled to run for several weeks, but considering the timeliness of the discussion, I would like to encourage all of you to watch it now from our website, prairiedoc.org. Just go to our site, click on the button that says, click here to watch Bringing Skyrocketing Healthcare Costs Back to Earth. This is important, non-political based information that's important for all of us to know. How do we bring this cost down as a nation? Now for tonight's show about the risks of using opioids for daily pain control, this is an important topic. First, let's take a look at this week's Prairie Doc quiz question. True or false? More people have died in the U.S. over the last 2 months from drug overdoses than from car crashes. True or false? Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We'll announce the answer and the winner at the end of the show. Remember, you have only 10 minutes to get your answer in. But we answer your medical questions about opioids all night long. So opioids for pain, chronic pain syndrome, what about pain? As they are called in and sent to us by Facebook or email. So call in your questions to 1-888-376-6225 or send us an email to the address on the screen. Joining us tonight is Dr. Craig Youthy from Sanford Health. Tell us a little bit about this issue. Why would you as a family physician teaching family physicians in Sioux Falls, why would you be asked to be on our show about opioid problems?
Well, as a family physician for 25 years, pain is a common symptom that we get in the office. Yeah. And chronic pain is something that we see all the time. And so
there's a difference between chronic and acute pain.
There is.
But let's get back to that later. Yeah. Go ahead.
And then I've had an interest in addiction medicine, and so I've become what we call an addictionologist. So I help people that have problems with substances. And then I'm the medical advisor for what's called the South Dakota Health Professionals and Assistance Program. So that's physicians, nurses, dentists, and pharmacists who have a drug or alcohol problem. I helped monitor them in their recovery.
See, now that's really important because you think about it, does that completely take them from ever being able to practice medicine if they become, down in the...
Yeah, no, we know that drug addiction or drug use dependence, we call it substance use disorders. That's alcoholism, that's being dependent on a drug. When you're taking those, you are not in a sound mind, and you may have a chance to have patient harm. So what we do is when those people are identified, they come out of their practice, they go get treatment for the illness. It's a disease no different than diabetes, hypertension,
it's a real
heart disease. And once it's treated, just like we treat diabetes, if diabetes is out of control, you go in the hospital, you get a treatment, you go back out and you live your normal life. That's what we do with people that have addiction. They lead normal lives.
And people who aren't in the medical profession, are the people in the medical profession more at risk than other people?
Yeah, that's a good question. We do know that young adults, when they go into medical school, they are at the same risk as the general population. Drug use disorders, alcoholism, it doesn't have a favorite. Anybody is at risk, or anybody could have that happen. Yeah. But we do know that physicians, medical students, residents, they have better access to drugs.
Yeah.
And so we do see an increased incidence of drug use disorders in medical professionals.
But people who have addictions, I mean, times you hear derisive, negative comments about an alcoholic person.
Yep.
That's really a real illness.
We're trying to get away from the stigma of this being something that's conscious for a person to be in control of. It's not. If we look at the brain chemistry, Dr. Holm, it's very interesting for us to see that I call it 3 components
Okay.
to chronic pain and how we deal with it. One is it's in the nerve endings. You have what are called mu receptors. Those are the receptors that are blocked by the opioids and give relief to pain.
So, I mean, we have pain receptors in our whole body.
Yeah.
They all go to the brain. The brain
Yeah.
says, there's pain.
Yep. And so we have these mu receptors.
That's mu receptors.
Yeah, then we have the cerebral cortex. That's our thinking part of our brain that makes us think, add, subtract, whatever.
Have a personality,
Yep.
communicate.
Yep. It's the decisions we make. That's another part of the brain. Then we have what's called the core part of our brain, the limbic, L-I-M-B-U-C,
Yeah.
limbic, B-I-C. And that is your core. So if a person is dying of thirst, they go and they look for water because they want a glass of water.
It
If
drives
get
you to
hungry,
breathe.
It drives you. It is the reward pleasure center of the brain. Some people have a very sensitive reward pleasure area. And if they get exposed to a substance that could be addicting, they may say all they want, that they're not going to do it, they don't want to do it. They don't have
can't
control.
It's
the
too
limbic
powerful.
system that controls it.
There's also the narcotic receptors in the brain. I mean, I remember the story of learning that they were looking at the narcotic receptors, and they used placebo versus narcotic pain relievers in people who had episiotomy
Yeah.
pain. That was the study.
Okay, sure.
We don't do episiotomies anymore,
Right.
which is you cut a part of the opening when the baby's coming out, and then the women have to
Sure.
recover.
Yeah.
Well, everybody had it.
Yeah.
So they could use different pain medicines, and they found that placebo worked 70% of the time, and the pain medicines worked 80%.
Yeah.
And then when they reversed the narcotic pain relievers with a narcotic reliever, the pain came back, right?
Yep.
And it worked as well when it was the placebo. The narcotic pain reverser, the pain came back
Yep.
even if it was just placebo.
Yeah.
So this whole narcotic receptor system in the brain, tell us more about that.
Well, we're learning more and more about the brain all the time. And so with these receptors, we find that the opioids will block them. But the other thing that we find is if a person takes an opioid regularly for 2 weeks and then stops the medicine, they likely will show some withdrawal symptoms to an opioid.
Right.
After about 2 weeks. Doesn't mean you're addicted. It just means that you will have some symptoms.
Withdrawal.
that
What
would
are
be
the
withdrawal.
symptoms of withdrawal?
I call it the weeping syndrome. You'll have tearing, your nose will run, you'll have mouth, watering of the mouth, salivating, you'll sweat, you'll get tremors, you get goosebumps, urinate frequently, you have diarrhea, you have muscle cramps, stomach cramps, insomnia, anxiousness. Those are the symptoms that you get with opioid withdrawal. Now, opioid withdrawal is not dangerous. Nobody dies from opioid withdrawal. They may want to, they feel like they want to die, but they will not die from an opioid withdrawal. People die from an opioid overdose. And guess what they die from?
Suffocation.
Respiratory depression. They stop breathing. So let's talk about the, how did this happen? I mean, how did we get to this dilemma?
I mean, I know that we have quadrupled the amount of narcotics use and abuse in 10 years.
Yeah.
Why did that happen?
Well, about 15 years ago, it was determined that we needed a 5th vital sign. So your vital signs are your temperature, your heart rate, your respiratory rate, your blood pressure. Oh, by the way, let's add pain.
Yeah.
And so we
so
added
they
pain.
added the
Yep.
pain thing. I
And-
don't know, 10,
yep.
1 to 10 scale,
Yeah.
right?
And I mean, everybody was very well-minded. They're altruistic, saying we don't want our patients to suffer, so let's get that pain to a 0. So we'll give them a pain pill with that. What we didn't realize is chronic pain does not respond to opioids like acute pain does.
Well, and also it's going to need to be given a long time.
Yep, and you can develop what's called a tolerance. So what 2 pills help take care of pain in week 1. By week 5, then it takes 3 pills to take away that same pain. That's called tolerance. Oh, another week later, it takes 4 pills. Before you know it, it escalates. What doesn't develop a tolerance is that respiratory depression. Okay, so if you get to a high enough dose, a person may not wake up the next morning. That's the danger.
Well, and I've heard that there is, of course, people start going to the black market, and then the black market, the doses that you get from your pills are not perfect, and you think you're taking X dose that you'll be, you normally get this high, or your comfort, or your pain goes away, whatever it is. But you got a double dose, and there's fentanyl in there, which is another
it's
one
a
of
patch. It's a long-acting opioid.
And so people get into deep, deep trouble, and they stop breathing.
Yeah, and the longer acting the opioid is, the longer the taper has to be to take them off it, and the longer that the withdrawal symptoms may last when a person stops the medication. So it can be very dangerous.
There's a lot of medicines that cause that tachyphylaxis dependency. What did you call it again?
Hyperesthesia you can get for pain intolerance.
So and a good example is stimulant laxatives like Senna. You take a Senna, oh wow, your constipation is resolved.
Right.
The next day it worked, but the third day it doesn't quite work, and the fourth day it's not working at all. You're using it every day, so you have to double the dose.
Right.
And then when you stop it, you have withdrawal constipation. It's the same tachyphylaxis, as they say, right?
Yes. Well, and another dilemma that we're finding is, so physicians well-minded, they have a patient population. I take care of Mrs. Jones, and she's 70 years old, and she's had chronic arthritis pain, and I put her on a long-acting opioid because that's what we were trained to do 15 years ago. Now here we come to 2017, and it's like, well, Dr. Youthy, that is not the recommended treatment anymore. I go back to the 1960s. Fred Flintstone used to advertise Winston cigarettes on television. We used to think it was healthy. Well, by 1970, we realized it caused lung cancer. All of a sudden, the doctors are saying, I'm not advocating, I'm not recommending you smoke anymore. We had it wrong. Well, I'm apologizing for our profession today for using opioids at high doses for chronic pain. It doesn't work. We know that. Because the pain they came in for 10 years ago is still there. And now they're dependent on an opioid. And they may be at risk of not waking up tomorrow morning in certain circumstances.
Right. I think the medical profession has made a mistake, and it is appropriate that we would apologize. We can do better, and we need to. Illegal use of drugs can put you in jail. Once there, what are the programs aimed at in helping the abuser to live a clean and sober life?
Opioids are a large group of drugs. Then some of those include codeine, fentanyl, hydrocodone with acetaminophen or Tylenol, hydromorphone of pain relievers like Demerol, morphine, oxycodone, methadone, bupropion, and heroin, which is illegal. There are some non-opioids, cocaine, methamphetamines, ecstasy, and LSD, just to give a difference of what are considered opioids and what are not. There's four main charges that we're going to see an opioid user come in for. They're unauthorized ingestion of a controlled substance, unauthorized possession of a controlled substance or drug, unauthorized manufacture, distribution, counterfeiting or possession of a Schedule I or II substance, and obtaining possession of a controlled substance by theft. Between opioid users and other drug offense users, there's not a huge difference because it all depends on how it affects that person. It all depends on how they're addicted to the drug. Earlier last year, I started a program, and they're coming in twice a week now. It's an hour-long program done on Wednesdays and Fridays with the inmates, and it's called the Peace Education Program. And what it is helping the people do is to realize that they've got some issues with why they're in jail to begin with and their charges and dealing with those charges, but it's also helping them trying to think in a little bit of different way to realize that their choices that they're making are affecting their life, and trying to help them make better choices so they don't get back into the same routine once they get out of jail again. We also do the 24/7 sobriety program, which a lot of people think that that's just for alcohol, but we also have drug testing on that program as well. So that could be a person coming in twice a week to get a urinalysis test done, or they could be coming in to get their drug patch changed. The intent of the whole program, of the 24/7 sobriety program, is to keep the person clean, whether it's for alcohol or drugs. And by doing that, then we're, it's plus just coming in and meeting with us on a regular basis, and we're hopefully keeping them clean long enough that they can start to break their habits some and till they get, some better help through treatment and things like that, and continue being sober.
Well, we really need your questions. We haven't called for questions yet, but here it is. We really do need your questions. It makes this a better show. This is your show. Call in your questions about opioids or pain or whatever you want at 1-888-376-6225 or send us an email to ask@prairiedoc.org. Mr. Sweeby, Officer Sweeby, they're making an effort to try to help people.
Which is wonderful. We do know that a significant number of our crimes are related to drugs and alcohol. Again, this is an addiction, this disease is. And by definition, addiction is defined as a chronic relapsing brain disease in which a person's behavior is such that they seek the drug despite harmful consequences, thus doing illegal activities.
And ending up in a jail.
Let me make this point, Dr. Holm. There are a lot of people that are on chronic opioids and they're prescribed by one doctor because they've taken care of their pain. And it's just hard for the doctor not to prescribe that. For you, for example, if you're taking care of Mrs. Smith for 25 years and she comes in, you've been giving her pain pills, and she says, you're going to stop prescribing my pain pills?
Yeah, I've had a change of heart, and I had a chance to kind of talk with Dr. Youthy, and now I've decided I need to stop your medicines. Whoop!
That's hard to do.
It is very hard to do. It's also takes time, and then they get mad at you.
Yes, well,
and
there's
you
hope.
like to be liked.
Yeah, there's hope. So one of the things that we've been finding successful and helpful for us is we will team up with the patient, and we will say, you are dependent on this medicine, but that does not mean you are a drug addict. That doesn't mean you're addicted to it. What I'm going to do is I'm going to help you taper this dosage down. We're going to get you off it over a period of time. We don't have a timetable. We're just going to start with slowing it. Our main goal is that you are not at risk to have an overdose death with that respiratory
We're trying to save your life.
So let's find other ways to treat your pain. And while we're finding other ways to treat your pain, let's lower the dose, and you help me lower it. We'll lower it at a rate that you can tolerate.
Right.
And some of these people go through mild withdrawal and are actually able to come off it. They just don't have the predisposition for addiction that some of the population has.
I think that's a genetic thing, isn't it?
Yeah, and it's about 10% of the population. Yeah. About 1 out of 10 individuals is at risk. Yeah. And there are some risk factors. If you're from a family history where there's a
lot of
history of drug
alcohol.
addiction, alcoholism, if you've had previous trauma in your life, that makes you more at risk to have some addiction tendency.
We need to talk about mental health with addiction, and we need to talk about chronic pain syndrome, but we have a question.
Okay.
What is the proper way to dispose of unused narcotic medication?
That's a great question.
That's a great question.
Gosh, I wish I would have brought it. There is a bottle, and it contains a substance that is basically carbon. So it's called activated charcoal, like we use Epicac type of thing. There it comes in a bottle, and you can actually put the pills into that bottle. It comes in a bottle that's like the squeeze bottle or a ketchup bottle in a restaurant. And they also have big jugs. So that's one way. Clinics will have it.
Drop off those containers, or you throw them in the garbage. Or, I have been told not to flush it, but to put it in the coffee grounds.
That is one way to do it. We still recommend that you then take them to a medical clinic or take them to a hospital and then have them disposed officially.
Yeah.
They can do that. They'll be willing to do it.
People, otherwise they're going through your garbage, aren't they?
Yep.
So the question I would have is, where do you get these containers? Where do you drop them off? Is there systems in different towns?
I would, wherever town you're in, I would call the clinic or I would call the hospital there, and they will be able to get you directed to the right resource. And there is a formal way to do that. Yeah, if you have been given a prescription for pain pills and you have multiple pills that are laying around, do not have them laying around.
You know, it's interesting. It was about 6 months ago. I was getting ready for a sailing trip, and I have a bunch of scopolamine patches, and I'm going through my medicine cabinet, and I found 3 bottles of hydrocodone with acetaminophen, you know, pain medicine with narcotic. One for a terrible throat thing that the ENT guy gave me that I never used. I mean, each of them were never used.
Sure.
So and I thought to myself, okay, are we at higher risk? Yes. I've got 2 nurses and 1 doctor in this household, and I threw them in the garbage.
You know, we are finding out as healthcare systems, there are things that we can do to try to decrease this risk of unintended deaths related to overdoses. And so trying to decrease the amount of drugs that are out there that people that have addiction will try to get their hands on. We want to get rid of that. So for example, surgeons now when they have a patient will have surgery, instead of giving you 30 pills, they may only give you 6.
Yeah.
That's appropriate. And it's a lot of times you don't need more. Now, if you need more for that acute pain, your doctor will give you the appropriate meds that you need.
And let's perfectly answer the question of what to do with the pills. And I would say, you know, one thought is if people don't know that you're a narcotic person or you've got narcotics, you know, the coffee ground's an option. But another option is bring them to your police department. Another option, bring them to your hospital. They'll take care of it.
They will take care of it.
And there are containers somewhere.
We do recommend not flushing them down
the toilet because it puts it in the water
or the sink
system.
because it gets into the water system. Good question.
I read an article that with chronic pain, your brain rewires and still senses pain whether or not you physically sense it. Is this true? That's exactly the question we need to talk about. Chronic pain. What is that and how is it different than acute pain?
Okay. Acute pain would be like
broken
leg, a second-degree burn, where the mu receptors are affected and an opioid will treat that pain and get rid of that pain. That pain is usually not sustained. As a bone heals, that pain will diminish. As that burn heals, that pain will diminish. But what happens for the person that's vulnerable for dependence on a drug, they still get pleasure or they feel a sense of well-being by taking the pain pill. That's the chronic pain. And so when I see a patient, I will ask them, now if they've been on pain pills for more than 3 months, I will ask them, what is your pain? Let's evaluate this pain further. And so we'll ask them, describe it. And it's a 1 out of 10. But they maybe say, my pain's an 8, but they have a smile on their face. And I'm not sure why that is. I believe they're having the pain. So what do we do about that? We find that molding of those brain tracts, we kind of get into these habits, or we get into these repetitions. That is affected. They can change, but it takes time to do that, to change it. So for the person that has chronic pain, we want to deal with that pain. But the second thing then we want to deal with is their dependence to this opioid.
And it brought to mind the issue of the number system. Just very same reason. I've come in the hospital. I've got this belly pain. So where's your pain on a 10 scale? I don't want to answer you that. I don't like the pain 10 scale. I have a significant amount of pain, and it's cramping, and it's right here, and it's not bearable. I mean, I'm really hurting. That's good enough. I don't want to give you a 10. Or an 8 or a 7 or a 3, you know, and then because I think, and you nailed it earlier in the show, that it has brought on some of this problem with that 10 scale.
I think
acutely maybe it's okay.
One thing that is helpful for us as physicians in trying to communicate with our patients, we'll say, I can't feel your pain, I don't know your pain, it's an 8 out of 10. Give me a different word for it. Now here's other words for pain. Agony, misery,
suffering,
discomfort, suffering. Give me, what are you feeling in that pain? Well, it's agonizing. I am suffering all the time. Well, how much are you suffering on a 1 to 10? And I'll say, well, I don't have a suffering pill.
Right, there's no suffering
There
pill.
is no suffering pill. There's more than that. And how are you functioning? Let's focus instead of on pain, let's describe it as suffering, and then see how you're functioning. If you're functioning and you're able to do that, let's work on that. Let's see what we can do to decrease your pain in your suffering.
Right. I look at a lot of chronic pain. For years, I used amitriptyline almost always for chronic pain as the first drug. And it's interesting how fibromyalgia, which is a chronic pain,
Yes.
not helped at all by narcotics.
Nope.
That kind of chronic pain is helped by the antidepressant group.
Yep.
And it makes you realize that if some kind of depression or some kind of mental problem didn't bring on the pain, at least the pain or the situation brought on has caused that mental illness. There's a strong tie there.
Very strong tie. We're finding that we are, for my fibromyalgia patients, it has been proven unequivocally, without a doubt, that long-term opioid use does not decrease or improve your function, decrease your pain for fibromyalgia.
Right.
Frustrating for the person that suffers from that.
Well, and frustrating for the doctor who's trying to help them.
Absolutely. So I encourage my patients, hey, get on a blog, get on the computer, find out what works, find what other people are doing for their fibromyalgia. If it's acupuncture, if it's massage, if it's heat, if it's ice, if it works, let me know what it is.
I heard this on NPR radio, the People's Pharmacy, which isn't my favorite show,
Okay.
but I catch it and I really like what they say. But anyway, so they had a orthopedic surgeon who wrote the book Back in Control.
Okay.
And he had had back surgery and he had
Okay.
had chronic pain and so on and so forth, and he realized the surgery didn't help him.
Okay.
And that surgery is often trying to be the answer for chronic pain, and it isn't.
No.
And but what he has done is suggested programs, and that's at the book. You can look it up on Amazon or wherever.
Okay, yep.
Back in Control. But one of his favorite treatments is 15 minutes of free writing in the morning. Doesn't mean that you can even read it. Doesn't matter that you read it. What matters is that you open your mind and just let it rip.
Yep.
And he said, I can tell from the very first visit if they're not doing it.
Okay. Interesting.
It's hugely helpful. And I think if we look at people with chronic pain, the most important thing we need to do is get them moving.
Yep.
Get them connected to other
Absolutely.
people.
Yep.
Forget about pills, because the pills aren't the answer.
No. Warm pool therapies, if you have access to warm pools, has been found to be very, very helpful. Music.
Music.
Music is therapeutic for some people.
I think singing. I think making music. Oh,
Yes.
Not to
Yeah.
say I'm a very good singer.
It's therapeutic for you, at
It's
least.
for me. I'm not talking about the listener. Could some of the opioid overdoses in the nation be due to the physicians prescribing it too often?
Absolutely.
Yeah, it's absolutely.
Absolutely. And again, it wasn't done intentionally. Physicians have not done it intentionally. But now that we realize it, we want to work with the patient to try to lower that dose. When I go in to see a patient and I say to them, you're taking these medicines, there's a chance you may not wake up tomorrow morning if you drink alcohol with this, if you take a sleeping pill with this. When you add things on top of it, besides the opioid, that's a risky thing. How can we help you to lower that dose?
Something like 3 out of every 4 deaths, 3 out of every 4 heroin users started with prescription pad written
they did.
narcotics.
And most patients get it from their primary care doctor, from one doctor.
Yeah.
Most.
Could some of the opioid overdoses in the nation be due to the physicians prescribing? Yes. What is fibromyalgia? We just talked about it. I would say the most important treatment for fibromyalgia is a walk, if you can, or walk as far as you can, and every day try to increase that distance.
When I was in my training 30 years ago, 20 years ago, the thought was we call fibromyalgia a diagnosis of exclusion. If we looked at everything else, we looked at lupus, we looked at rheumatoid arthritis, we looked at bone disease. If we couldn't find out the answer, we called it fibromyalgia.
Yeah.
That's not doing justice to the person with fibromyalgia. We know that fibromyalgia is real. When that patient comes in with fibromyalgia, we know it's quote unquote not in your head. It is a real pain condition. We just don't have a good treatment for it yet. Now there are discoveries out there. There are new medications that are being tested. Medicine is not the answer for this condition, however. It's a complex condition, the person has fibromyalgia. And trying to find little things that help, from sleeping well to moving to finding stretching, all those things makes a difference. Everybody's a little bit different.
Interaction with your fellow human faith-based support, the idea of interest in something besides you, because what they've been doing
Oh, yeah. Yeah.
is me, forget about me,
Yep.
get involved, listen
Yep.
to your friends.
And my fibromyalgia patients will tell me the busier I can be, the less my fibromyalgia hurts.
Yes.
I mean, so if they can be distracted, and they realize that. For some, it's very difficult and very frustrating for those patients.
We actually, many people who abuse drugs are not violent, and there are other programs besides prison that can help.
Grew up over in Seattle, was born and raised out there. Grew up in a good family, good home. Parents divorced when I was 2 or 3 years old, and went on to college out in Seattle at the University of Washington, where I pursued a degree in civil and environmental engineering. And so, that's when I started to kind of go down the path of partying. My last day of college classes, I was just up to no good at a party, and I fell and I broke my lower leg in 3 places. And they did surgery, and I have a plate and 7 pins in there, and that was when I first started taking some painkillers. The whole month was kind of hazy. I smoked a lot of marijuana in addition to it. Healed up just fine. Started my career with this firm in downtown Seattle. My life was really great, to be honest, but I just felt empty, like there's got to be something more to this life. And it just ate and ate at me. And I'd just go home and I'd just go get drunk or get high and hang out with friends and just kind of pass my spare time away that way. It got to the point where I attempted suicide. It was not successful. I got prescribed some antidepressants, ended up in a psychiatric hospital for about a week, where they put me on a whole bunch of other medications, Risperdal, an antipsychotic, Ambien, a sleep aid. I remember the doctor writing on a piece of paper, psychotically depressed, and just holding it up for me to look at, and I remember just being totally crushed, like, I'm not a psycho, I'm just Ian. Shot into a manic episode again, like usual, ended up robbing a trailer, getting in a fight, and I was looking at some serious prison time. So when I was in my jail cell one night, and I was hearing just voices in my head telling me, you're a mess, look what you've done with your life. You're 27, you've had all the privilege in the world, you've been given a lot of gifts and talents, and you squandered it, and you're sitting in this jail cell, you might as well kill yourself. And it was like 5 or 6 layered voices.
A lot of our guys come to us through the court system because their addictions kind of lead them into a path, down a path rather, that's destructive and sometimes criminal. We don't really believe that addiction in and of itself is the main problem. We think it's a big problem, no doubt, but we believe you have to reshape the heart, and you have to deal with yourself as a person and face reality and take responsibility for all your choices.
We could have done a whole show with Mike and Ian there, and I think Teen Challenge. I tell you what, I've been involved with helping Teen Challenge through the years. This has been a very, very successful program for men who have had the deepest addictions, and it's like a 16-month program, and they come out of it.
It's great to have that. I mean, those are individuals who they don't feel just bad about themselves. They think they are bad, and they feel shamed. And you're really trying to help them realize that this is a disease that you had no control over, and so to accept that, acknowledge it, but then move forward. You've learned from it. You can be a champion now.
Yes, you be the champion. You talked about 3 buckets. Let's hear about that.
When I have a patient that has chronic pain and that they're dependent on opioids, there are 3 things that patient deserves. One is they need to have that pain thoroughly evaluated. And when I go into a consultation on a patient that has chronic pain and is on opioids, Usually they've had a thorough evaluation of that pain, and so we don't have to focus on that when I see them.
No more CAT scans. I mean, how
No,
many CAT
yeah, right.
scans do you need to
Yep,
have?
MRIs, and I would say, but 99.9% of patients will tell me, no, it's my pain, and I understand that.
My pain.
Yep, I understand that. I say, but there are two other components that you really deserve and need to have evaluated. One is your dependence on the medicine. And somebody might say, well, are you calling me a drug addict? And I say, no. I'm just saying that you're dependent on this medicine. If you were to stop this medicine at the dose you're taking right now, you'd have withdrawal symptoms. And so that's just that's a real thing. So I really want you to see a licensed counselor who specializes in alcohol use disorders, substance use disorders, and get a thorough evaluation so they can help you for that, to see how lowering this medicine can help you, and walk you through that. And then the third thing is over 50% of people with chronic pain and on an opioid have an underlying mental health illness: depression, anxiety, sleep disorder, trauma in their past.
Post-traumatic stress syndrome.
Post-traumatic stress disorder.
Coming back from Iraq,
Yep.
that whole story.
Those three components should be addressed, because we're finding that a lot of the suffering, which is the pain
Yes.
that the patient's having, if you treat that underlying mental illness, guess what happens to the pain?
Yeah. Lot,
drops.
Yep. I almost always will start with an SSRI, and I know, it's another pill,
Right.
and I'm not trying to push pills, but when you can help them with the depression, because I think it's huge under the chronic pain and fibromyalgia group as well.
I sense in our profession that we feel pressure to prescribe a pill. We were trained that way. It's an American culture. It's an easy fix. My patient wants them. I want my patient to be happy. I want them to like me. I'm going to give them the pill.
And they leave with
Yes.
something in their hand.
And yes, but we're trying to, as a profession, trying to resist that temptation when it may not be the best
Right.
step to take.
Particularly for the elderly, because
Particularly for the elderly.
because that will decrease your, no matter how you look at it, all of those pain medicines, the neuroleptics as well as the sleeping pills and the narcotics, all depress your mental capacity. I had one lady, the family came in, she's demented.
Yep.
And okay, well, what we'll do is we're going to taper off these drugs in a slow period, controlled way, and we'll just see how much dementia we have. Blossomed, came alive again.
Yep. I've had patients come in, they've been brought in by a spouse or an adult child and said, hey, I want my mom back again. She just doesn't think clearly. She's doing goofy things. And we think it might be the meds. And the only way to know if it's the med or not is to stop it or lower it and see what happens. And it's amazing how many chronic pain patients feel better when they come down on their dose. And what my experience has been is the higher the dose they're on of medicines, so let's say they take 8 pain pills a day, to get them down to 4 pain pills a day, I'm amazed at how many say to me, I feel better. I'm able to move my bowels easier. I don't have abdominal pain as much.
I'm we
more
need to
alert.
We need to get to questions, but there is a advertisement on TV for another pill to counter the constipation
drives
from
me.
the narcotic. I
Yes.
just ate it.
I do too.
It tells
a
us
pill for the pill.
it's the worst
It
example
is-
of what we're doing.
Yes, it is so self-incriminating.
Are there opioids that we could find in our everyday medicine cabinet at home?
Yes, so they're controlled substances, meaning that you have to have a written prescription. If you're not sure, I would call your doctor, call the clinic, call your nurse, call your team, your healthcare team, and say, these are the meds I'm taking. What are they? So, hydrocodone, oxycodone are common ones. There's the brand names are like Vicodin, Norco.
What about
is another
Tramadol?
one. Tramadol is also a controlled substance.
It's a narcotic. It has a little bit of an antidepressant component to it.
Here's the thing with Tramadol. Okay, Tramadol, if a person takes 300 milligrams a day or more, they're at risk of having a seizure. And that's what I see with Tramadol.
And it's a long-acting, it
so
builds up.
It's a 50 milligram tablet usually. So if a patient takes more than 6 Tramadols a day, they're at risk of having
Big
a
time
seizure.
danger. And with that, sometimes tramadol has Tylenol with it, which
Yep.
can kill your liver.
Yeah.
So, I mean, bad
Yeah.
choices. Is there a safe over-the-counter painkiller for a 78-year-old man with osteoarthritis in the spine and knees? And I would say movement is your very best answer. They talk about they did the big studies with bad knees, bone on bone. They took half of them and they left them in the couch to
Yep.
sit there and the other half to move. And then who had the least amount of pain? The movers. And who were more mobile, who were stronger,
Yep.
who were happier. So that's
Now,
your
I
number
would,
first.
I would talk to your physician about it first of all, because they will know. Yes, medicines can be taken for that kind of pain on a limited basis, temporary. Let's say you're a golfer at 78 still, or you want to go walking, or you want to go somewhere with a family. Tylenol, ibuprofen, which is Motrin, Advil,
Right.
naproxen, which is Aleve.
Right.
Yes, they can be, but again, there are, for every good thing there is with a drug, there's also
Bleeding
some side effects.
and
So,
and, you
so
know,
a person has a history of ulcers, you wouldn't want to take them.
No.
But the answer to that question is yes, there are safe medicines to take, but talk to your doctor about
and
it.
periodically. I mean,
Yeah.
here's so I'm going through radiation, some belly pain that's with that.
Yep.
I take 2 Tylenol every other day,
Yep.
maybe. Go ahead.
When it comes to, I do prescribe opioids. I prescribe them for acute pain.
Yeah.
That's there. I might have a person that has rheumatoid arthritis and they're on their rheumatoid arthritis medicine. They said, I'm going to the Black Hills for my 50th high
Here.
school reunion. Here's 3 pain pills for you to take
Yeah.
along with you.
Right, and maybe just
So,
a touch of.
Yeah, it's not that I don't prescribe it. We just have to be careful with it.
Right, I agree. All right, answers to quick questions. We've got a ton of questions. Do common OTC pain medicines have negative interactions with opioids? Actually, the acetaminophen enhances the opioid
Yep.
and it works better for
Yep.
pain. Actually, it might be the acetaminophen that's doing
Yep.
some of the pain.
Again, I would talk to your doctor about it. You can never err by just calling your doctor and saying, can I take this with this? What do you think?
Good.
There can be an additive effect.
Here's a tramadol question. I've had 4 back surgeries and I've been in pain for 3 years ever since the last surgery. I've been taking tramadol for the pain, but now I feel addicted to it. Is there anything I can do besides take tramadol for pain? And the answer I would say is back and control. Get that book. Get off of pills if you can.
Strengthening your core muscles is a huge thing. We talk about core exercise. There is, again, when it comes to chronic pain that you have it, you'll probably not get rid of it, but can you function with it and can you improve? Now, I would say if you have chronic back pain and it changes, go back in and see your doctor because there can be something that's going
Right.
on. If there's a change in your chronic pain, address that.
If something's happening with foot drop
Yep.
or weakness in your legs or
Yep.
problems in your feet in
Yep.
particular.
Heat, ice, pool therapies, massage, chiropractors. I mean, if it helps and it's not a pill and you can get relief from it,
Go that way.
I would go that route.
70-year-old male with chronic back pain has 5-6 level lumbar fusion, states he can have surgery, but the risk is quite large. He's been hydrocodone for the last 10 years. Take 4 10-milligram pills a day. The pain is starting to increase again. How long should this be expected? What can he do next?
Okay.
It's probably not surgery. It's going to be
Probably not. Again, it depends on the situation. If you think there's been a change in the pain, go get it reevaluated. If it's been 18 months since you had that reevaluated, there might be something that could be checked again. 4 10-milligram hydrocodone pills a day, that is not a level that is thought to be at risk for an overdose death. There is a scientific
still a fair amount of it.
There's something called the morphine milligram equivalent dose. So physicians can actually quantify, they can find the number that you're on. If you're over 100, that's at risk for an overdose death. This gentleman's at 40. If he could stay at 40 and that pain was tolerated and he's seeing his doctor and they have a pain agreement that's signed that he's not selling it, that type of thing.
Right.
And you have trust between the doctor and the patient, but that the pain's escalating, he's either developing tolerance where that medicine's not working anymore, and increasing the opioid gives him the side effect potential.
I'd try to get off the opioid and
It might actually be
gradually-
better if you can get off the opioid.
It sure
and
would
find
be.
other
He may find that
options.
he's a lot less pain.
Yep.
Caller has pain in her legs when she's been resting for an extended period of time and the legs continue to swell. It's wondering what can be done to help. Pain in your legs from leg swelling is a whole different problem. But I would say support hose, elevation support hose, get the edema out, talk to your doctor about more medicine maybe to get rid of edema.
If it's acute pain with acute swelling of a leg, we worry about like a blood clot. So get in and see your physician if it's something that just started.
If it's acute, yeah, there it is. Are there any non-narcotic drugs to take for rheumatoid arthritis? Yeah.
There are medicines specifically for rheumatoid
Methotrexate
arthritis.
is one of the magic drugs of all time.
Yep. And again, heat wax therapy for rheumatoid arthritis is
And a
helpful.
rheumatologist always helps because that's the person who
Yep.
may be the best with this. I send them all
Yeah,
to
and the
rheumatologists.
problem with that is these medicines can have significant side effects. So you really, really want to have a team between your primary care and the rheumatologist working together in that.
Okay. Caller takes several Vicodin a day, wondering if marijuana would be a suitable replacement.
Okay. Great question. I mean, that's a controversial one right now.
Well, there's
Again,
CBD. You know, there's this marijuana that
Yeah.
is not so addictive.
Yep, that's another issue. Again,
10 seconds.
Yep. With marijuana, it is also a mood-altering substance, and so there is risk behind that.
dependency, yep.
And so it's a route I would recommend not taking.
It might be helpful too.
A path not taking.
That's not illegal in this state.
Yeah.
And now for the winner of tonight's Prairie Doc quiz question, true or false? More people died in the U.S. over the last 12 months from the drug overdoses than from car crashes. True or false? Craig?
It is true.
According to the CDC, the number of overdose deaths in 2015, overdose, was 52,404. Compare that with the number of people who died of car crashes being 37,757. 52,000 from overdoses from narcotics.
Yeah.
It's terrible. It was Arlene Schaefer from Tripp, South Dakota. Arlene, yay! You answered the question. Thank you, Arlene, for participating, and a book will be in the mail to you soon. We'll be right back. Well, do we have a few seconds to talk about this? No. We'll be right back after this.
All around town, from stores to playgrounds, babies are on the move. And there are diseases that are on the move too. And some of these spread easily. To best protect him from 14 serious diseases by the time he turns 2 years old, vaccinate him according to the recommended schedule. So he can go on about his business and you can have peace of mind. For more reasons to vaccinate, talk to your child's doctor or go to cdc.gov/vaccines.
We are in the middle of an opioid overuse and overdose epidemic. Opioids, also known as narcotics, are either processed from the white tears of scored opium poppy fruit or made synthetically. Legal prescription opioids include morphine, oxycodone, hydrocodone, fentanyl, tramadol, whereas all these alone or in combination with heroin, methamphetamine, and cocaine are sold on the black market. An estimated 16 million people in the United States are abusing prescription or black market opioids, including 20% of our high school kids. Abuse is one thing, but death is another. According to the Center for Disease Control, from years 2000 to 2015, the number of opioid overdose deaths quadrupled, with more than 500,000 people suffocating to death from opioid overdose during that time. 91 U.S. citizens are dying from opioid overdose every day. Embarrassing news for the healing professions is that at least 1/2 of these deaths are from prescription medicines. And 3 out of 4 heroin users were addicted initially to legal opioid pain medicines prescribed for so-called legitimate reasons. When they no longer can get a refill of the prescription pain medicine, they turn to heroin. This has happened during the era of the electronic medical record with progressively obsessive government monitoring and discouragement of narcotic prescribing. I personally believe this speaks to how impotent oversight is in effecting control or change. Causes for this deathly epidemic are myriad. For more than 20 years, we have been encouraged to ask patients to rate their pain on a 0 or 1 to 10 scale, and quality parameters rate us poorly if we aren't addressing their pain needs. Additionally, our whole culture has been almost hypnotized by pharmaceutical advertisements telling us that the answer to every medical problem is a medicine, which is obtained if you ask your doctor. Take it from me, it is easier to prescribe a pill than to say no to a demanding patient. Still, we must say no. Treatment for chronic pain means listening, encouraging movement, and insisting the return to function and work, not prescribing opioids. During the last 15 years of quadrupling of narcotic prescriptions, there has been no change in reported pain across the U.S. Simply put, chronic pain responds poorly to narcotics. It's always rated 11 on the 1 to 10 pain scale, and opioids should be avoided, therefore, in treating chronic pain. We're in the middle of an opioid overuse and overdose epidemic, to which there will be no end until doctors and patients say no to opioids and yes to movement and return to function. We didn't get to all of your questions, but the questions will be posted on our website. Go to our website, prairiedoc.org, and get those answers. We'll do that after hours. You can see it. Well, it's a big thank you to our guest, Craig Youthy, who
Thank you.
we're just grateful for on your own dime, your own time, you come up here and you volunteer to be a guest on our show. We thank you so very much. Your
My
insight
pleasure,
is
privilege.
wonderful.
Thank you.
You are a talent. And influenza and activity, it has decreased but remains elevated in South Dakota. We're not out of the woods yet, folks. If you haven't gotten one this season, you may want to consider getting your flu vaccine now to reduce your chances of catching the flu bug as the season moves forward. Don't forget, next year. Well, that does it for tonight. Remember to go to our website, watch our special program about healthcare costs, or get the extra questions that were called tonight. Go to prairiedoc.org. From all of us here at On Call with Prairie Doc, until next time, stay healthy out there, people.
Balancing act with blood sugar levels. Too much or too little are neither good nor healthy. The not-so-sweet life of diabetes. Next time, On Call with the Prairie Doc.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota, and with the ongoing support of these individuals and institutions: Brookings Health System, Ophthalmology Limited, South Dakota State Medical Association, Avera Heart Hospital, Dakota Allergy and Asthma, Fishback Financial Corporation, Vance Thompson Vision, Aberdeen Asthma and Allergy, Black Hills Medical Society, Dakota Bank, Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, Regional Health, Swiftel Communications.